So what we did was we created a system. We used Six Sigma plus value-based healthcare and came up with Measura AI. We embedded it with an artificial intelligence engine. We're not using new technology. We're using existing technology that we have used for 20 years, but we've made it run faster and run together and combined it with hazard ratios of known data points or blood testing. We put it all together and are able to make this thing run. Instead of taking an hour and 20 minutes to do our analytics, we can do the analytics in 20 minutes. And so we're able to get data points faster and we're able to take care of it faster. How the system works is that we put a technician in your office. That technician helps gather data from your patients. They work right at your front desk with your staff on the intake. They do things like height, weight, calculate BMI, get the demographics of the patient. We have them actually measure height. It turns out that most patients don't tell you the truth about their height. They're average by 1.5 inches. And so if they're off by 1.5 inches and you don't measure it, your BMI is completely wrong. And even though BMI is not an exact measure of health, as in terms of obesity, it's still what the federal government is dependent upon. But you also want to get an abdominal girth because the abdominal girth is directly correlated to viscerogenic obesity. And it is part of metabolic syndrome. You know what's not part of metabolic syndrome? LDL-C, triglyceride, HDL, waist circumference, blood pressure, and fasting glucose are all in there. What's not? LDL-C, because it has no correlation to outcome, none. And so we get that data and we do a review of systems or an index of suspicion. 93% of the general population will qualify to have Measura, but of your population that's seeking medical care, it'll be 99%. If they have any pain, if they have any nerve symptom, if they have any evidence of discomfort, if they have any hearing loss, if they have any dizziness, if they have any memory changes, if they have nausea, if they have vomiting, if they have any cardiovascular symptoms, if they've got elevated blood sugar, any of those, any one point gets them qualified to get into the Measura protocol. We use our AI engine to drive what is the necessary testing for that patient. So for example, if they have a family history that's positive for cognitive impairment, our whole intake only takes us 3.5 minutes, and we gather that information pretty quickly. We will measure ApoE4 on that patient. If they're homozygous, they have a 95% chance of becoming Alzheimer's. If they have a high homocysteine, we know that they're high risk for Alzheimer's. If they're ApoE4 positive homozygous, 95% chance they're going to get Alzheimer's, and the drug that we use costs $85,000, but it only has a 1% effectiveness rate. Now, if I put them in a lifestyle coaching program, that's a 25 to 40% effectiveness rate at a much lower cost. So the federal government's very interested in lifestyle coaching. The number one cause of liver transplantation right now in the United States is fatty liver. It's the number 2 cause of GI doctors being sued, that they missed the fatty liver. You completely miss it if you use SGOT, SGPT, but you'll completely get it if you use GGT. And GGT correlates more with a 5-year lifespan than any of the other liver function tests. And in fact, on actuarial data from Credit Suisse, they consider it the most important marker of liver health that we have. And most docs have never measured it. And yet you can measure it, and it's a standard of care that we can easily do. So what we're looking at is reversible causes of disease that we can easily get results on and have good correlative information and give the patient advice. So step 1 was take the data intake. Step 2 is to draw the necessary testing. Step 3 is once we've got that necessary testing back, 4 weeks later, we do their Measura testing. Whether it's an ANS or a pseudomotor or an ABI or a respiratory quotient, vestibular balance, are they at high risk for falls? Are they having any of these other issues? We do this, the average reimbursement per set of testing per time is between $400 to $450. And that's a conservative number based on a Medicare-Medicaid mix. Your average test frequency will be 2.1 to 2.5 times a year. The results from this are generated as a percentage. So if you were at 80% health, your chances of having a cardiovascular death event, all-cause mortality event in the next 5 years is 1 chance in 55,000 to 1 chance in 65,000 if you're at 80%. If you get down to 60%, your chances go to 1 in 20,000 of death. If you get down to 30%, you have a 1 chance in 5. And what's interesting is these numbers will rapidly change. Just like you have a CGM that you give to patients and they say, hey, my glucose in the morning used to be 160 and now it's 110, you know that that patient's getting healthier. In this particular case, as their numbers change, you know exactly what's going on with them. They'll tell you correlative information like, hey, I came in originally and my percentages were like 34% and I couldn't get an erection, and now I can get an erection and I don't even have to take the Viagra anymore. Because it's measuring things like nitric oxide. We do a plethysmography. It's measuring things like RQ. The reason why we use RQ is that half the time when you do a thyroid hormone, you can have a normal TSH and a normal free T3, but you might be half the time have a decreased BMR. And the only way you're going to figure that out is to measure exhaled CO2 and intaked O2. And normally that test would have taken you 35 minutes to do, and you'd have to have a metabolic cart. We've put all of those tests together in one set, and it only takes about 20-25 minutes. So we're able to bundle testing together and run it simultaneously rather than run it linear, run it one at a time. So we do that testing. We give you the codes, we give you the billing, you bill the testing, and you collect the money. 30 days after you've been paid, you pay us our portion, which is 40%, and you keep 60%. If we bill something and it doesn't get paid, you don't pay us at all. And that means that if we made the mistake of not getting a pre-cert, you're not responsible for it. We cover the cost of the technician, the testing, the disposables, and all the equipment. If the technician is somebody you don't like, then we change them out. If the technician isn't doing a great job, you don't have to worry about it, because that's our responsibility. Now, the next step is if you decide that you want to do lifestyle coaching. You don't have to do this step, but there's a fair amount of money in this. And the typical code is done by Telemed 98960, and it's education and training of patient self-management by a qualified non-physician healthcare professional using standardized curriculum. It says face-to-face, but it also allows Telemed till 2026 right now. You can also, if you want to do direct care, there's separate codes for those. You can bill up to 26 lifestyle coaching codes with a counselor that does not involve your direct care. Now, if you want to do direct care, you can do that supplementary, but it's not required for this ancillary service to be billable.